Hello and welcome to Chapter 22, Abdominal Emergencies for the EMT. So, we are going to talk about abdominal anatomy and physiology, some abdominal pain or discomfort, abdominal conditions, and assessment and care of the abdominal pain or discomfort. So, anatomy and physiology. So the abdomen contains many organs from several different body systems. It can cause confusion when determining the cause of the abdominal emergencies, and a thorough patient assessment is key. And a specific diagnosis for these patients isn't necessary. The treatment is the same for most of these conditions. So the abdomen is the region between the diaphragm and the pelvis. Contains many organs and organ systems that provide the following functions: digestive, reproductive, endocrine, and regulatory. Okay. So these are the organs of the abdomen. So we've got some solid organs, which are the spleen, the liver, the pancreas, and the kidneys. These do not have a space in them, and they're just basically one big mass of solid organs. Our hollow organs include the stomach, the gallbladder, the duodenum, the large intestine, the small intestine, the bladder. Okay, all of those are hollow organs. They hold something, so that way they can. The abdomen is divided into quadrants. So we've got the right upper quadrant, the left upper quadrant, the right lower quadrant, the left lower quadrant, and the epigastric region. So your right upper quadrant is here, left upper, right lower, left lower. Your belly button or umbilicus is right here, and then your epigastric is right here. So organs of the abdomen. So we've got the peritoneum, which is a thin membrane lining that covers the cavity, the abdominal cavity, and it covers each organ as well. The parietal peritoneum is attached to the abdominal wall, and then the visceral peritoneum covers each organ. So most are enclosed with in the parietal peritoneum. A few lie in the extraperitoneal space, such as the kidneys, the pancreas, part of the aorta lie in the retroperitoneal space behind the peritoneum, and the bladder and the part of the rectum lie inferior to the peritoneum. Okay, so this is a cross section of the torso. So this right here, when we look at it at the abdomen, starting up here at the spleen and the liver, you can see that there is kind of a line that goes around these organs. Those are your peritoneum. That's your peritoneum. Your kidneys, your ureters, your abdominal aorta, all of that is retroperitoneum, and it sits outside of this cavity. Okay, and then your bladder and part of your rectum sit outside of that cavity as well. All right, so let's talk about pain or discomfort. So there's visceral pain, which originates from the organs within the abdomen. There's fewer nerve endings that allow for only diffuse sensations of pain, so it's frequently described as a dull or achy pain. Colic or intermittent pain may result from distension and or contraction of hollow organs. It's persistent or constant pain that often originates from the solid organs. Parietal pain originates from the parietal peritoneum. There's many nerve endings that allow for specific and efficient sensations of pain. These are frequently described as sharp, and the pain is often severe, constant, and localized to a specific area. Tearing pain. So this is the most common type of abdominal pain, and it originates in the aorta. It's caused by the separation of layers because of this large blood vessel that's caused by an aneurysm. Retroperitoneal location of the aorta causes pain to be referred to the back. So when we talk about referred pain, that means that it's not necessarily the pain that's there, but it goes to the back. Okay, again, perception of pain in skin or muscles at distant locations. The abdomen has many nerves from different parts of the nervous system. That nerve pathways overlap as they return to the spinal cord, and the pain sensation is transmitted from one system to another. There's different types of referred pain. When we talk about referred pain, we talk in the abdomen, like your appendix. So there's an old theory that says that if you hit the bottom of the bottom of the foot, that you'll get a sharp sudden pain in the abdomen, or you'll get a sharp sudden pain in the shoulder. This would be called referred pain. So abdominal conditions. So appendicitis. So it's an infection of the appendix. Signs and symptoms are nausea and sometimes vomiting. Pain is often initially referred to the umbilical region, and it's followed by a persistent right-left quadrant pain. Rupture of the appendix is sudden, causes a severe increase in pain, and it's when the contents of the appendix release into the abdomen, causing severe peritonitis. This is a surgical procedure. It has to be taken care of surgically. So peritonitis is the irritation of the peritoneum, usually caused by a foreign material into the peritoneal space. The parietal peritoneum is sensitive, especially to acidic substances. Irritation can cause involuntary contractions of the abdominal muscles, and signs and symptoms include abdominal pain and rigidity. Cholecystitis or gallstones. This is an inflammation of the gallbladder. It's often caused by blockage of its outlet by gallstones. Symptoms are often worsened by ingestion of fatty foods, and signs and symptoms include severe right upper quadrant pain or epigastric pain, and pain that's often referred to the shoulder. These patients can also become yellow, similar to cirrhosis of the liver, but it's the gallbladder that's causing the pain. Pancreatitis is inflammation of the pancreas. It's commonly caused by alcohol abuse, and signs and symptoms are epigastric pain and often referred to the back and shoulder. GI bleeding. Oh Lord, these patients, the first time you smell a true GI bleed, you will know that it's a GI bleed because it's a very specific smell. I always think to myself that a EMS book of smells would go wonderfully. But GI bleeding has a specific smell. Once you smell it, you'll know it. Like sometimes you can walk into a nursing home and smell that GI bleed, just like you can with like UTIs and various things like that. So what's happening with a GI bleed? So we've got hemorrhage within the lumen of the GI tract. It can be severe to minor, and then blood eventually either exits the mouth or the rectum. It's often painless. The only reason that they know that they have a GI bleed is blood coming from the rectum, or they're throwing up blood. Gastric ulcers, they're holes in the GI system from highly acidic gastric juices which can cause severe pain and peritonitis. So signs and symptoms of GI bleeding. So you've got dark colored stool. It's maroon to black and often tarry. Frank blood from the rectum. So that bright red blood from the rectum is usually a hemorrhoid. Vomiting is of a coffee ground appearing blood, or vomiting of frank blood, that bright red blood. Pain can be absent to severe. The bleeding, the difference between the bleeding is where it's at. So if it's a dark, tarry colored stool, then what you're looking for is, or what you can figure out and deduce, is that the bleeding is coming from somewhere in the upper GI tract, because it takes a while for that blood to get out, so it starts to turn that dark tarry color. If it's the bright red, then you know that it's in the lower GI tract and it didn't have as far to go down. Same way with the vomiting of the coffee ground emesis. That coffee ground emesis is somewhere in the lower GI tract, because it has to come up through back to, the stomach and then the mouth and everything like that. If it's that vomiting of the bright red blood, then we know that it's in the upper GI tract, more so like in the stomach or in the esophagus. So it's like esophageal varices or something like that. Okay? Or esophageal ulcers. So abdominal aortic aneurysm. So this is a ballooning or weakening of the inner wall of the aorta. It tears and separates from the outer layers, causing a dissection. Weakened vessel bulges, and it may continue to grow and may eventually rupture. If you have a patient who has this problem, then what you're going to do is not touch the abdominal area. Okay, so let's talk about the signs and symptoms, because that'll make more sense. So progressive and often sharp or tearing abdominal pain frequently radiates to the back, the lumbar area. It's a palpable abdominal mass, possibly pulsating, and possible inequality in the pedal pulses. If you have an abdominal mass that is pulsing and pulsating, do not touch it, do not push on it, do not do anything with it. This patient needs immediate surgical intervention. That's the only thing that's going to fix it. And if they have a rupture of the abdominal aortic aneurysm or the abdominal aorta, remember back in like chapter 6 where we talked about how the blood flows through the body. So it goes up to the ascending aorta, to the descending aorta, into the abdominal aorta, and then it branches out into all the organs and the body and everything like that. So that is a main vessel. So if that bursts, then we've got lots of problems. Okay, so we've got internal bleeding, and really we can't do anything. Me, even as a medic, I can't do a whole lot to stop that bleeding. They need a surgeon. I can give them fluids, but I'm not going to be even anywhere near close to keeping up with those fluids to keep up with the amount of blood loss. Okay, so a hernia. This is a hole in the muscle layer around the abdominal wall. This allows tissues and parts of the organ, commonly the intestines, to protrude up against the skin. So if you see like a small bulge, that's typically a hernia. Some patients will put their hernias back in themselves and just push it back in when it happens, because they have it all the time. They know that they have this weakening of the abdominal wall, and it just pops out. They pop it back in, and they're good to go. It can be precipitated by heavy lifting. They're straining. They're using their abdominal muscles to lift. So when they use those abdominal muscles to lift, it stretches and allows the organs or whatever to protrude up into that hole. This can cause strangulation of the tissue or even a bowel obstruction, and it may require surgical repair as well. I had a patient once who we get called there. She's got massive pain in her abdomen. When we get there, I see that she's got this hernia, and it's just massive pain for her. So get her into the back of the truck. We move her, and what happens is when we move her, the herniated organ goes back into where it's supposed to go, and we fixed the problem basically. And she just let out the sigh of relief, didn't have any more pain, or she had limited pain, but it wasn't like, horrible pain like it was. So sometimes that can happen. So sudden onset of abdominal pain, often following exertion. There's a palpable mass or lump on the abdominal wall or crease of the groin, and we call that an inguinal hernia. So renal colic. This is a severe flank pain caused by kidney stones traveling down the ureter. Signs and symptoms include severe cramping, intermittent pain, or in the flank or back. And it's frequently referred to the groin. So in these patients with kidney stones, it's a severe pain. They need to be taken care of. They have to be given some pain medicine. They will describe, depending on where it is, they will describe this pain as a traveling pain. And when you ask them, did it go from the back to the front? And they say yes, then you're probably like 99% sure that it's probably a kidney stone. Because what it's doing, that kidney stone is going down into the ureter, into the bladder, and then hopefully to get excreted by urine. But sometimes it doesn't and requires surgery or a medicine to make the kidney stone smaller so that it can't be passed. So cardiac involvement in the abdomen. So pain from an MI may be felt as abdominal discomfort. Sometimes it's epigastric pain, digestion, or indigestion or digestive discomfort. So we always want to consider the possibility of a cardiac emergency as a cause of abdominal symptoms. Okay, so now we're going to watch this video of an abdominal aortic aneurysm.
The most common location of abdominal aortic aneurysm is between the renal and iliac arteries. An aneurysm is luminal dilatation caused by degenerative changes in the aortic wall, leading to an increased vessel diameter and bulging of the abdominal aorta. Eventually, the degenerative changes may lead to rupture of the aneurysm.
Okay, so I hope that kind of makes a little bit more sense on how that works and how an abdominal aortic aneurysm works. So, all right, so assessment and care of abdominal pain and or discomfort. So there's many potential causes of abdominal pain. It's not necessarily for us to diagnose that abdominal pain because there's so many things that it could possibly be. We want to be on the right track and make sure that, what we're treating them for is what we're actually doing, and that it's the right plan of care and the right treatment course. So again, we can't necessarily diagnose these out in the field because we don't have ultrasound, we don't have a CT, we don't have an MRI. So we can't really diagnose these things just by looking at the patient and them telling us, hey, I have abdominal pain right here. Something that I always ask a patient is, if in my secondary assessment, I'm a hick. I come from the country, and I ask them, do you have all your innards? And, they'll tell me whether or not they have their gallbladder, their appendix, if they've had a hysterectomy, if they're female, or if they've had, part of their colon replaced, or, something like that. So those questions are always good to find out. And then you can pretty much narrow it down to what may be the cause of the problem and treat. But again, most of your treatment is the same, barring any kind of serious or life-threatening conditions. So seeing size up, protect yourself from bloodborne pathogens. Be aware of odors. Again, those odors of the GI bleed, UTIs, all of those things are very prominent, and you can tell them. We're going to determine if the patient's condition is a medical, trauma, or both. In our primary assessment, we're going to do our general impression, do our ABCs. We're going to assess their level of consciousness, consider supplemental oxygen to the hypoxic patient. So, history of the present illness. So we're going to do onset. When did it begin? What were you doing? Provocation. What makes it feel better or worse? Movement or position. Sometimes these patients want to bring their knees up to their chest. This is a sign of guarding. So you've got to be aware of that. So if they want to just sit curled up or like in a fetal position, this is a sign of guarding. They're trying to guard their abdomen from being hurt anymore. Quality. Describe the sensation in your abdomen. Radiation. Does it go anywhere? Severity. How bad's the pain on a scale of 1 to 10? Time. Do you have any pain at all? Do you have pain all the time, or is it intermittent? Has it changed? Okay. Specific to female patients, we want to know when their last menstrual cycle was, if it may be late. Do you have any bleeding from the vagina? If that is not menstrual bleeding. If you are menstruating, is your flow normal? Another question you could ask is it possible you're pregnant? Are you using birth control? Have you ever had this pain before? And if yes, did it happen? When did it happen, and was it like this? Okay. So our past medical history, we're going to go into our sample. So signs and symptoms, we're going to do allergies, medications, past pertinent medical history, last oral intake, and any events leading up to the emergency. Okay, so on a geriatric note, they have the decreased ability to perceive pain. It's more serious causes of abdominal pain, more likely to be life-threatening, and they may be complicated by medications as well. So physical examination of the abdomen. So we want to look for, on our inspection, we want to look for distension, discoloration, or protrusions. So with those protrusions, we're looking for any kind of hernias or anything like that in the organs. Discoloration, we're looking for bruising. The various stages of bruising. So like, if it's like a purple blue, then it's probably new bruising. If it's more of a yellow type color, it's probably an old bruise. Distension, we're looking for, basically you'll see distension fairly rapidly the first time you see it. Their bellies will be big, abnormally big for the size of their body, and it'll be hard to the touch. So palpation, we want to use the fingertips, and we want to go to the painful area last, because if we push on the painful area first, then that pain is there, and you can't really tell where the pain is the rest of the way. when we do palpation, we're really just kind of looking for any kind of enlarged organs or anything like that. Okay, so again, we're looking for rigidity, pain, guarding, anything like that. So, you know, if the patient winces when you push on the right upper quadrant and they told you that it was the left lower quadrant that had pain, then, you know, we've got to figure out, you know, where is that pain actually coming from, because it may be referred as well. And then guarding, we talked about guarding a little bit. So vital signs, we want to do baseline, then every 5 minutes. We want to do, again, pulse, respirations, blood pressure, skin color, temp and condition, pulse oximetry, and mental status. Okay. So general abdominal distress. So some will result from digestive system disorders. Others could be cardiac or diabetic issues, food poisoning, or flu. We want to assess and care for these patients with appropriate attention to airway. Particularly if the patient is vomiting. Always work to calm the patient to reduce their anxiety, and never give the patient anything by mouth. Mainly because if we're going to give anything by mouth, then we've pretty much negated a whole lot of things for surgery. Because not that we negated surgery, but we may have postponed surgery or done something like that. So we want to make sure that we don't give anything by mouth. It could also do more harm because the digestive system has to work. And if there's something already not working in the digestive system, then it could be bad. Okay. So maintain the airway, be prepared to suction, administer oxygen to that hypoxic patient, place in a position of comfort, and maybe the left lateral recumbent for airway protection, transport to an appropriate facility. So let's do some thinking. So you have an 89-year-old female with a history of diabetes, hypertension, and gallstones. It's complaining of nausea and dizziness about 20 minutes after eating. So what are your concerns with this patient? So concerns with this patient, you could be looking at gallstones. She's got a history of gallstones. Okay. Maybe a diabetic emergency since she just ate 20 minutes ago. Maybe she had too many carbs, or she didn't eat the right things. Could be just food poisoning. Okay. So we want to look at those things, and her age. She could be cardiac. Okay. This patient is a high risk for a cardiac emergency. So we want to, look at all of those things. So then we're going to kind of narrow those things down. So, how do we narrow those things down? Well, we can rule out a diabetic emergency with a blood sugar, right? So then we're left with a cardiac and abdominal emergency. So she is high risk. So you want to call ALS to go ahead and maybe do a cardiac workup on her, so that way they know how to get all that done or what they need to do. Okay, so how do we know? So our assessment, okay, assessment can really lead us down the right direction of how we're going to treat our patient, and what we need to do. So for this patient, we're going to do vitals, history, a good history of this patient, and oxygen if she needs it, and then we're going to call ALS. Okay. All right. So chapter review. So all complaints of abdominal pain or distress must be treated as serious emergencies and require transport. So as an EMT, it's your responsibility to primarily assess the patient and report your findings. Field diagnosing the cause of an abdominal complaint is often more difficult and time-consuming than diagnosing in the emergency room, where there's many resources available to them. Your assessment should include a thorough patient history, a physical exam, and vital signs. Again, it's not something that we want to necessarily know the exact cause from, but we want to know, as much as we can about that problem, and we want to know how we can fix that problem. So look for signs and symptoms that can signal serious trouble. These include sudden onset of tearing pain, radiating to the back, vomiting blood or coffee ground emesis, the presence of black tarry stools, or signs and symptoms of shock. Emergency care will consist of protecting the patient's airway, oxygen as needed, placing the responsive patient in a position of comfort, placing that responsive patient or patient with difficulty maintaining an airway in that left lateral recumbent position, and transporting to the hospital. So we're going to take all appropriate standard precautions and carefully clean and disinfect the equipment in ambulance, especially if they vomited or had diarrhea. So things to remember: abdominal organs provide a variety of important functions to the body. The abdomen can be divided into 4 quadrants with reference to the midline and umbilicus. Classifications of pain can help identify specific abdominal dysfunctions. Our assessment and management always takes a higher priority when determining the exact cause of that abdominal pain. Knowledge of the characteristics of specific abdominal disorders can aid differential diagnosis when assessing a patient with abdominal pain. Care for a patient with abdominal pain should include treatment of immediate life threats, administration of oxygen, placing that patient in position of comfort, and appropriate transport. Again, things to consider, questions to consider when you finish out this chapter, and reading and everything like that. So, what are 5 signs and symptoms of abdominal distress? I want you to name 5 of them. Describe the difference between visceral and parietal pain, and describe a condition that may be responsible for each. So what is the emergency care for a patient experiencing abdominal pain or distress? And name the 4 abdominal quadrants and how are the quadrants determined. Alright, so you are called to a patient with abdominal pain. He describes the pain as severe and says that it has been on and off over the past several days, becoming severe within the past hour. What additional questions would you like to ask the patient? In what position would he likely most be comfortable? So let's start with the first one. So what additional questions do you want to ask? We want to focus on where the pain is, where it starts from, and so on. And then we want to determine, previous history of the present illness. We want to do our OPQRST. We want to do our sample. We want to do all of those questions. And we also want to know, specific abdominal questions as well. Have they had good bowel movements? Have they had good urinary movement? Any of those questions. Have they had vomiting? Have they had diarrhea? Was there anything in the diarrhea? Was there anything in the vomit? All of those questions you want to ask, okay? So then what position would he most likely be comfortable in? Position of comfort for this patient. I mean, whatever he's going to do. If he wants to sit up with his legs drawn to his knees, if he wants to lay in the fetal position, he's more than welcome to. Okay. All right. So if you have any questions, comments, anything else, let me know, and I will answer those. You can email me, call me, text me, whatever's easiest. So, and I'll answer those questions. And I will see you on the next lecture.